Okay, so tonight we are going to finish the anatomy lower limb. In the anatomy lower limb, we have to do the same as we did in anatomy upper limb, and we are going to start with the bones of the foot. So let's take a look in our 3D in the very first place about the bones. So is it clear for everyone?
Yes.
Okay.
Yes, sir.
It's clear.
Fantastic.
Yes.
So what you have to know is some certain bones. Please mute yourself all. There are so noise. Please, everyone keep muted. Okay. So in the very first place, you have to know the name of the bones. So this is the calcaneus. Then you have the talus. This is the talus. This is the talus. Then this is the navicular, cuboid, medial cuneiform, intermediate cuneiform, lateral cuneiform. Okay, so this is the bones of the foot you have to know. Very first place, the larger one is the calcaneus. Then you have, again I'm saying, the talus, then the navicular, the cuboid, the medial cuneiform, the intermediate cuneiform, and the lateral cuneiform. In a very simplified way. Is it clear? Anyone has any doubt?
No.
Okay. So if there is no doubt, then what you have to identify in your real exam is from this picture. Okay, please mute yourself, everyone. There is a noise. Okay, from this picture you have to identify the same bones, okay, but from this picture. So let's start with the larger one as always. So number 13 will be the calcaneus. Number 11 is the, please everyone mute yourself. Yes, the talus. Next one is number 15. This one is the navicular. Number 10. Here, this is the medial cuneiform. So in the picture A, what you are seeing the bones of the foot from the medial aspect. Okay. Again, I'm going. This is the calcaneus. This is the talus. Number 15 is the navicular. Number 10, it is the cuneiform. Also, you can see number 2 here, which is the cuboid bone. If you see the bones from the lateral aspect or the lateral side, the same thing you are going to see is number 17 is the calcaneus. Number 7 is the talus. Number 15, it will be the navicular. Number 2 is the cuboid. Then you can see the cuneiforms. Okay, so this is the medial one, the medial cuneiform. Number 5, it will be the intermediate cuneiform, and number 6 is the lateral cuneiform. Is it clear? Now you can unmute yourself.
Yes.
Yes.
Okay.
Yes.
Yes, sir.
Yes.
Okay. Because why I'm asking you to mute, because there are very noise. There are so much noise in the background. So please keep yourself muted, because when you guys will be listening to the recorded version, you will have so much difficulty to hearing. Okay. So mute yourself, everyone. I will ask you, and you can unmute yourself and talk. Okay. If the bones are clear, okay. Next, there are a few things you have to know. So from this from this 3D, what you can see, there is a arch, right? So this is the medial surface. That means you are having a medial longitudinal arch. And if you see from this view, that means this is the lateral longitudinal arch. Okay, this is the lateral longitudinal arch. And if you see from this aspect, so it will be your medial longitudinal arch. Also, you can have a transverse arch if you see from the front. So this will be your transverse arch. Okay. So there are mainly 3 arches. So the question is, okay, before that, we have to know few ligaments as well. So about the arch, you can see the same picture I have put also, but you have to know the arches in a very by your heart, because in the exam you will be asked these arches and also their components. So as I said, on the medial aspect, you are going to have medial. On the lateral aspect, you are going to have lateral. And if you are seeing from the front, then you're going to have a transverse arch. Next is you have to know about some ligaments. Okay. From the medial aspect, on the medial aspect, there are mainly you can see 3 main ligaments. One is the plantar calcaneonavicular ligament. Can anyone tell me what is the other name of this plantar calcaneonavicular ligament? Anyone has any idea?
Spring ligament.
Spring
Fantastic. Fantastic. This is the spring ligament. Fantastic. Okay. And other 2 ligaments is a long, this is the long plantar ligament and the short plantar ligament, if you are seeing from the medial aspect. So we will try to see the same thing, but we'll be seeing this from this. Let's try to see the same thing here. So it will be a little bit easier for you. This is okay. So what you are seeing here, this is the long plantar ligament. Okay, in the 3D model, it is difficult to show you the short plantar ligament, and also you can see this one. This is the plantar calcaneonavicular ligament, which is also known as the spring ligament. Okay, this is on the medial aspect. So they will ask you, what are the components? What are the components of the medial longitudinal arch? How the medial longitudinal arch is formed? How the lateral longitudinal arch is formed? So you can see the medial longitudinal arch will be formed. First of all, let's talk about the bones. Okay, so if you are talking about the bones, so what are the bones? So first, the calcaneus. Okay, then you have to have the cuneiforms and also the metatarsal. So what are the cuneiforms you are going to have? The 3 cuneiforms. Okay, so first is the calcaneus, and you can also think about the talus, because it will be arched like this. Okay, so the calcaneus, the talus, the cuneiforms, the 3 cuneiforms. Okay, what are the 3 cuneiforms?
Medial, intermediate, and
Intermediate and lateral.
Fantastic.
What about
And
navicular?
no need,
Yeah.
not included here.
Navicular is not involved with medial arch.
No, only the calcaneus, talus in, okay, if you want to say like this, yes, you are correct. Then so you are going to have all the three what I said. So the calcaneus, talus, and navicular like this, right? You can see in a curved fashion. Yes, then you can say the three cuneiforms, which is the medial, intermediate, and the lateral cuneiforms. Dr. Shakwat, you are right. You can include the navicular because you are thinking about the full arch. Okay, so add
Yes.
the three,
Yes.
all of them three. Then again, you have the metatarsals. So you are going to include the three metatarsals as well. Okay, these are the total 9 bones when you are thinking about the medial longitudinal arch. Next, you have to think about the ligaments and the muscles. Okay, first, let's talk about the muscles then. What you are going to have? You're going to have the tibialis anterior. You're going to have the tibialis posterior. Also, the flexor hallucis longus. Okay, and you're going to have some ligaments. So, what are the ligaments you can have? One is the spring ligament, and also you're going to have some, anyone? I said
Interosseous
the
deltoid ligament.
The
Long,
long
Sorry?
ligament.
long plantar.
Yes,
Long plantar ligament.
yes, the long plantar ligament and the spring ligaments. Okay, the long plantar and the spring ligaments, and also you can have
Deltoid.
this.
The plantar aponeurosis. The
See
plantar
here.
aponeurosis.
See here. This is the spring ligament. Also, you can have the long plantar ligament and also the short plantar ligament, just by the picture. Okay, by the picture. So
So I think the short plantar is a part of the lateral longitudinal arch.
the both arch can share few common ligaments and few common muscles, no problem. Suppose the peroneus longus, it is the main the common components of all the three arches. Okay, so
Okay.
one component can share in different arches, no problem.
Okay.
So about the medial longitudinal arch, again I'm saying the bones, 9 bones: calcaneus, talus, navicular, 3 cuneiforms, 3 metatarsals. About the ligaments, the short and the long plantar ligaments and the spring ligaments. And also you can have the muscles which are the tibialis anterior, the tibialis posterior, the flexor hallucis longus, and always remember the peroneus longus. The peroneus longus is the common muscle which will be there in all the 3 components of the arches. Is it clear about the medial longitudinal arch?
Yes, sir.
Okay, let's talk about the lateral one then. So in the lateral one, what you can see here, first of all, again, you're going to have the calcaneus. Okay, next one will be this is the cuboid. So calcaneus, cuboid, and you're going to have the 4th and the 5th metatarsals. Okay, so here, number 1, calcaneus, number 2 is the cuboid, and number 3 and 4 will be the 4th and 5th metatarsals. These are the bones. Okay, on the ligaments, what are the ligaments you are going to have is only the short and long plantar ligaments. Okay, about the muscles. So I said you're going to have one common muscle in all the arches, which is the peroneus longus. Okay, peroneus longus. So add with it the peroneus brevis. So you're going to have the muscles on the lateral longitudinal arch are the peroneus longus plus the peroneus brevis.
Can you
Okay.
repeat please about the peroneus longus?
The peroneus longus is the common common muscle which you are going to have in the medial longitudinal arch, in the lateral longitudinal arch, and also in the transverse arch. This is the common. Okay.
Okay. Okay. So in lateral,
Obu bhai,
Yes.
you are there is so much noise from your side. I don't know why.
okay.
No, you can
Maybe
ask, no
because of
problem.
the fan. Maybe because of the fan.
Okay.
Is it now clear?
Yes, now it's fine.
Okay. Okay. Now it's clear.
When you talk, it's clear, but when you don't talk, there is a sound, something like a fan, maybe. Yes.
Okay. Okay. I'm taking
All
it
right.
back. So in the lateral arch, there is peroneus longus and brevis, the ligamentous fracture.
Sorry.
In the lateral longitudinal arch, there is two ligamentous fracture. One is peroneus longus and the other is brevis.
No, it is the muscle. The ligaments are
Sorry,
short
it's
and
the
long
muscle.
plantar ligaments.
Short and long part. Okay. Okay.
Yes. Yes. Okay. About the transverse arch. So in the transverse arch, the components. So mainly, first of all, the bones. So bones are the base. Okay, these are the base of all the 5 metatarsals. Okay, only there will be a bones and one single muscle will be the components of transverse arch. What will be the muscle? The peroneus longus. Okay, and the bones are the bases of all the 5 metatarsals. Okay, is it clear about the arches?
Yes, sir. Clear.
All right. Everything is written.
It would be
okay.
more clear if you, I think, sir,
Please.
it would be more clear if you show some figures related to ligaments and muscles.
Yes, we will see the ligaments. We will see that.
Also muscles.
Okay.
Sir, what are the function of the arches?
1 second, please. So you wanted to see the muscles, right?
Yes, sir, and also spring ligament.
Yes. I'll try to show. Okay, let's then, first of all, let's see the ligaments. It's a bit difficult to show. Okay. Let me just do one thing then. 1 second. Okay. Now it will be clear for you, I guess. Okay. So this is the medial surface, right?
Medial aspect.
Mm-hmm. So if you can see now, this is the long plantar ligament. Clear? The short plantar ligament is difficult to show. Okay. The short plantar is difficult to show in the 3D. And this one is the plantar calcaneonavicular ligament. Okay.
Or spring ligament.
This is known as the spring ligament, Dr. Fatima. Clear?
Yes, sir.
Okay.
Yes, it is.
Okay. So this is the plantar calcaneonavicular ligament. This is the long plantar ligament. Okay. Now let's try to see some muscles then. So if we put few muscles, so this is the flexor hallucis brevis. This one is the FDL, and this one is coming from back, and this is the flexor hallucis longus. So on the medial one, main one, okay, the main one, it is the flexor hallucis longus. Also, you are going to have the you are going to have the one more muscle you want to see. Yes, this is the tibialis anterior, okay, and also you should be given, there should be a tibialis posterior as well. This is the tibialis posterior. This is the tibialis anterior. Okay.
Okay.
About the muscles. So these are the muscles and also the ligaments. Is it a little bit clear? Because in 3D model, it's a little bit difficult to show, but I'm trying to show you. Okay. Is it a little bit easier or clear?
Yes. Yes,
okay.
sir. Yes,
okay.
sir.
It's clear. Okay. Now you have to learn few more ligaments. Okay. So on the medial aspect, what we learned the long plantar one, and also we learned about the spring one. But there is a big ligaments we have to know, and this is a very important ligament, which is the
Deltoid.
Yep, this is the basically it is the broad and fan shaped. Yes, okay. This is the tibio-navicular ligament. Also, this is normally known as the deltoid ligament. On the medial aspect, you have to know about the medial about the deltoid ligament, which is very important. If you can go on the lateral aspect, you can see few other ones. So this is the calcaneofibular. This is the anterior talofibular, and there are another one, which is the posterior one. If I can hide this, this is the posterior talofibular ligament. Okay. So on the medial aspect, we learned three main ligaments. One is the deltoid, then the spring and the long plantar ligament. Okay. On the lateral aspect, what we had mainly the anterior talofibular ligament, the calcaneofibular ligament, and on the posterior aspect, what we have, we have the posterior talofibular ligament. Is it clear till now?
Yes.
Yes, clear.
Okay.
Yes, sir.
Also, on the posterior aspect, what you can see here, there is also another very important ligament is the posterior tibiofibular. You can clearly see, right? It is between the, and the ligaments are by their name. So you are going to have the ligaments in between two bones. One is the tibia and another one is the fibula. So this is the posterior tibiofibular. Okay, but the problem is you have to identify these from some pictures like this. Okay, so first of all, in the picture C, what you are seeing this from the medial side. So
Medial side.
yes. So here, number six.
Deltoid ligament.
Deltoid ligament.
Deltoid.
Yes. So here, number 6 is the deltoid ligament. Okay. About the deltoid ligament, what are the things you have to know? So you have to know about the attachment of the deltoid ligament. Okay. So superiorly, on the superior aspect, it will be
Medial
attaching.
malleoli.
Yes, fantastic. With the medial malleolus. Next, below it will be having a attachment with the sustentaculum tali. Okay. Sorry, I didn't show you which one is the sustentaculum tali. In this picture, number 18, this is the sustentaculum tali. Okay.
Sustentaculum tali.
Yes. Okay. This is the sustentaculum tali, and in this
thala is a part of which bones?
calcaneum.
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 Is it a joint? Sustentaculum tali?
No. It's just a impression, bony impression.
Oh, okay.
Of the calcaneum.
Okay. The deltoid ligament. You can see this is somewhat L-shaped, right? Somewhat L-shaped because it will be having some attachment. So first of all, superiorly, as you said, it will be attaching with the medial malleolus. Next, below, it is attaching with the sustentaculum tali. Next, it will be attaching with the body, of the talus, body of the talus, and also here is the neck, okay, with the neck of the talus. And as you can see, number 18, this is the spring ligament. So the deltoid will be having some attachment with the spring ligament as well. So again, superiorly with the medial malleolus, inferiorly with the sustentaculum tali, along with the head of the talus and also the neck of the talus, and also with the spring ligament. Is it clear about the deltoid ligament and their attachment?
Yes.
Okay.
Yes.
Number
Yes.
26 is the
Number
navicular bone or something.
Navicular bone.
Number 26, it is the tuberosity of the navicular.
Navicular bone.
Okay. Number 15 is the medial malleolus. Number 16 is the deltoid ligament. Number 18 is the spring ligament. Number 14, it is the long plantar ligament. Number 17, it is the short plantar ligament. Is it clear?
Yes.
That's it. Yeah.
Sir,
Is
can
there
I
any
ask a
attachment with
question?
navicular bone?
Sorry.
Any attachment with navicular bone?
Here with the tuberosity of the navicular. Here you can clearly see, as I said, number 26 is the
Navicular.
tuberosity of the navicular. So here will be the deltoid attachment. There will be also some part with the tuberosity of the navicular bone. This is a clear picture
Yes.
of the attachment.
Yes.
Okay.
Okay.
On the lateral aspect, of the foot, you need to identify again few ligaments. Okay, as I shown you on the lateral aspect, what you are going to have, very important, the calcaneofibular ligament. So this is the calcaneum and this is the fibula, right?
Fibula.
So
Right.
if you can see this ligament, that means this is the calcaneofibular ligament.
Fibula ligament.
Okay, calcaneofibular ligament. And also here in a very short, number 1, if you can see, this is the anterior talofibular ligament, as I shown you in the 3D. So this is the calcaneofibular and this is the anterior talofibular ligament. Okay, because this is the talus and this is the fibula. So the talofibular ligament is number 1. Okay, so which one will be the posterior talofibular?
19.
19.
Fantastic. So number 19 is the posterior talofibular ligament. Okay, so from this picture, there are nothing much you have to identify other than these few simple ligaments. Are all the ligaments are clear for all of you?
Yes.
Yes, clear.
Okay.
In the picture E, is the 25 is deltoid ligament? Just to know. 25.
Number 25. It will be the. I don't think
Is
it is
it
a.
deltoid?
I don't think it is a deltoid. It will be a tibiocalcanean part maybe. Okay, but you cannot say is a. It is a complete
The
part
picture
of the
is not-
deltoid. Yes, because you cannot see the full part of the deltoid, right? So you can say it can be a
Right,
part
right.
of the deltoid.
Part of deltoid. Okay. Okay.
Sir, do
Mhm.
we have to know about the origin and insertion of the deltoid ligament on or
No.
are all the ligaments that
Only
you have shown?
no, only the deltoid ligament. What I said about the attachment. Only
Okay.
you have to know that. Okay. Also, I have
Al-
put. Please.
And sir, in the above mentioned picture which you showed, do we have to learn all the labelings from 1 to 26?
No.
Or just
The only I showed only. Okay.
okay.
The things I have shown or I have mentioned, you have to go through just only all of those, nothing more.
Okay.
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 So here is a
Okay.
very beautiful picture as well about those ligaments. Okay. When you are you have some time, just see this, and this is a very nice picture about the same ligaments, and just go through all of those whatever I just said. Okay. This is a very nice picture as well. Okay. So again, there are few other pictures from where you need to identify as well. Okay. And some pictures like this. So let's try to identify the same things, but from a different picture, and also some of the joints as well. Okay. So first of all, in the picture, this picture, is it clear for everyone, this picture?
Yes, sir.
Yes.
Okay. So if I ask you, what will be, okay, first of all, let me know from which aspect you are seeing this.
It's from the lateral aspect.
Lateral aspect of the right foot.
Fantastic. This is the lateral aspect from the right foot. On the lateral aspect, what are the ligaments we are expecting to have?
Posterior tibiofibular.
Plantar, long plantar ligament.
Mainly the anterior.
Posterior calcaneofibular.
Calcaneofibular
and calcaneofibular.
And calcaneofibular.
Okay.
Calcaneofibular, anterior, talofibular,
Yes.
and
Yes.
Posterior.
Anterior and posterior
Okay.
talofibular.
Let's go one by one. Okay. So first thing first, if I ask
number
you
7.
number 4, okay, this is number 4 will be the anterior
Tibiofibular ligament.
tibiofibular. Yes. So you can see it is coming from the tibia and attaching with the fibula. So this is the anterior tibiofibular ligament. Okay. Next one. If I ask you about number 5, so you can see this is between the talus and the fibula.
Anterior talofibular ligament.
Fantastic. So it is the anterior talofibular ligament. Okay. About the number 7, okay, you can see this is the calcaneum. Yes. So this is the calcaneum and this is the fibula. Okay. So it will be the calcaneofibular ligament. Okay. What to know more from this one? So you can see a little bit of number 13, which is this one, right? This one. And as we know, this is the long plantar ligament. Fantastic. Fantastic. Okay. Now we have to know about few joints from this picture. Okay. So the first joint we have to know is number 18. So it is showing a joint. Okay.
Number 18, right.
Talonavicular
ligament.
It is the talonavicular joint, or
Calcaneonavicular.
Calcaneonavicular.
this one.
Calcaneonavicular joint. Between
Talus?
talus, calcaneum, and the navicular.
Yes.
Calcaneum and navicular.
Fantastic. It is the talocalcaneonavicular joint. Okay. Also, this is the head of the. This is the head of the talus.
Talus.
Fantastic. What
Talus.
about this joint? This joint?
Calcaneocuboid.
This is the calcaneocuboid joint. Fantastic. Okay. What is the name of this joint as a whole?
Chopper joint.
Chopard joint.
Fantastic. So this is known as the joint of Chopard, or
Metatarsal joint.
metatarsal joint. Metatarsal joint. Okay. So in the metatarsal joint, there are two separate joints, right? One is this one and another one is this one. So the calcaneocuboid joint, it is what type of joint?
Synovial.
Plain synovial.
Plain
Plain
type of
synovial.
synovial.
Plain synovial.
Plain.
Saddle type of synovial. No.
You can say this is the
Ball.
no. Ball and socket is the which part? This part will be the
Ball and socket.
yes.
Talonavicular is ball and socket.
Plain type of synovial joint.
Yes.
Calcaneonavicular cuboid.
Yes. Okay. In the next picture, this is from the medial aspect. Okay. Please everyone mute.
Medial aspect.
Okay. Everyone mute, please. Okay. From on the medial aspect, what are the ligaments we are expecting to have? First of all, the deltoid one.
Deltoid ligament, spring
So
ligament.
number 23. Number 23. It is the deltoid. Okay. Again, we can see something on number 13. Number 13 is the long plantar ligament. Okay. Also, we can have these. What else? What else we are looking here or expecting to have?
Spring ligament.
Spring ligament.
30.
Which one?
Spring ligament.
30.
Number 30, and this is the also known as spring ligament is also known as the plantar
Calcaneonavicular.
Fantastic.
Navicular ligament.
So from this picture, one is deltoid, second one is the spring, and the third one is the long plantar ligament. Okay, these are the
Long
three ligaments
plantar ligament.
you have to know from this one. Okay. All right. Fantastic, guys. Excellent. Okay. So let's talk about the, as I said, about the joints. So in the joints, first of all, you have to know about the subtalar joint. What does it mean by the subtalar joint? Below the talus, right? And there will be articulation with the calcaneus, the superior surface. So if the examiner asks you what are the articulating surfaces of the subtalar joint, so what you are going to say is the inferior part of the talus along with the superior surface of the calcaneus. Okay. What type of joint is this? This is the plain synovial joint.
Type of synovial joint.
What are the movements?
Inversion.
Inversion and eversion. Inversion and eversion.
Eversion.
Next joint is talocalcaneonavicular. Talocalcaneonavicular joint. So this part and this part, okay? Talocalcaneonavicular joint. So if the examiner asks you what are the surfaces, so there will be head of the talus, okay, the head of the talus articulating with the navicular and also some part with the calcaneum. Okay.
Calcaneus.
So this is a synovial joint, but here the talonavicular part, which is this one, is a ball and socket type of joint. Okay. And what are the movements? There will be gliding and rotatory movement. Gliding and rotatory movement. Okay. The third one is the calcaneocuboid. So this is the calcaneocuboid joint. Okay. The calcaneocuboid joint is the plain synovial joint. And what are the articulating surfaces? So you can see clearly the anterior end of the calcaneus. It will articulate with the posterior surface of the cuboid.
Surface of.
Okay. So the calcaneocuboid joint, it is also the plain synovial joint. And what are the movements will be happening here? Again, the inversion, eversion, and also some sort of circumduction. Is it clear about the joints?
Yes.
And which one is the joint of Chopard?
Mid-tarsal joint.
Talocalcaneonavicular and calcaneocuboid.
joint.
Okay, so this is the joint of Chopard or the mid-tarsal joint. Clear?
Yes, sir, clear.
Okay. Next, we have talked about this. Okay. What are the muscles will perform the action of inversion and eversion? So let's try to see in the muscles. So can anyone tell me what are the muscles will cause the inversion?
Tibialis anterior. Tibialis anterior and posterior.
Okay. So this is the tibialis anterior, right? Let's see what is the movement. So tibialis anterior has two movements. One is inversion.
Plantar flexion and
Also, no. What's
Dorsiflexion.
dorsiflexion? Clear?
yeah.
Yes, sir.
This is the dorsiflexion and this is the inversion. Okay. All right. Next, if we talk about the everter, what are those? The peroneus longus and fantastic. So this is the foot eversion. Okay. Clear?
Yes.
Okay. So about the muscles, mainly inverters are the tibialis anterior and also some sort of posterior, but the eversion will be done by the peroneus longus and brevis. Okay, about the type of joints, we have already talked about that. Okay, but mainly, what is the type of the ankle joint? This is the synovial hinge. Okay, why? Why?
Only plantar and dorsal.
Two type
Plantar
of
flexion and dorsiflexion.
dorsal and plantar.
So you can see this is the ankle joint, right? This is the ankle joint. And this is a hinge type of joint. And what are the movements there will be?
Dorsiflexion, plantar flexion.
Yes, this is the posterior aspect and this is the anterior aspect. So there will be dorsiflexion and the plantar flexion. Okay. About the what type of joint is the inferior talofibular joint? This is the syndesmosis.
Syndesmosis.
Syndesmosis
Okay.
joint.
Syndesmosis,
joint.
because it is the fibrous joint. Okay.
Yes.
And what type of fracture? What will be the associated injury? If there is a lateral malleolar fracture, okay, then there will be an injury into the syndesmotic fracture.
Syndesmosis.
Sir, is this the Weber fracture?
Yeah, you don't need to classify the Weber in part D. That's for part A only.
Okay.
Yes, but you are correct. You are correct. Okay. What are the bones? What are the bones forming the ankle joint? What are the bones?
Excuse me, sir.
Tibia,
Sir, excuse
fibula,
me.
and talus.
Yes.
Hello.
Yes, Shagun.
Sir, in here, we just studied the subtalar joint is a plain synovial, but I think you have written there the subtalar joint is a ball and socket. Just
Where?
go to the text. So can you
Where?
just move on to the text that you have just shown?
Where?
A bit above. So what is
Yes,
the type of
it should
subtalar
be.
joint?
It should be the plain synovial joint.
Okay, plain synovial. Okay,
Plain
fine.
synovial joint.
Thank you.
Okay. All right.
All.
So now, what are the parts of what are the bones that will form the ankle joint? So from this, what you can see?
Tibia, fibula, and talus.
Yes.
Lower end of tibia and fibula.
The lower end of the tibia and the fibula, and
Fibula.
along with
Tell
Trochlear surface of
or
talus.
trochlear surface
Yes.
of talus.
the talus. Okay. Fantastic. Next is, as we said, what are the movements of the ankle joint? So you have the plantar flexion and also you have the dorsiflexion. Okay. We will talk about the muscles in a bit. Okay. So in the anterior compartment, we have the muscles of tibialis anterior, extensor hallucis longus, extensor deuterum longus, and the peroneus tertius from the lateral side, right? And those are the muscles are responsible for the dorsiflexion of the foot. And what are the muscles?
These are
of
from
the-
medial to lateral, sir. No?
Yes, you can say that, no problem. You can say if you want to organize them. Yes, fantastic, you can say. Okay, about the movements of the ankle joint, what other movements? That is the plantar flexion. And for the plantar flexion, you have two compartments, right? The superficial and deep. The superficial, you are having the GPS. Okay. And on the deep aspect, you are going to have the tibialis posterior, the flexor deuterum longus, and the flexor hallucis longus. All of those muscles will be responsible for the plantar flexion of the ankle joint. Okay. We will talk about the muscles in a bit. About the this question, this is a very nice question. Ankle joint is most stable in dorsiflexion. Why? Very simply, one point, always remember, in dorsiflexion, when the foot is dorsiflexed completely, you cannot move your foot. While your foot is in plantar flexion, you can have some sort of inversion, eversion movement. So when your foot is in plantar flexion and you can move your joint, that means your foot is in vulnerable condition. And in dorsiflexion, there will be no movement. And the question is why there will be no movement? Because normally what you have the talus, right? And the talus, it is mainly wider anteriorly. Okay. I can show you something, I guess. Okay, no picture here, no picture here. No. Okay. From this picture, if you can see, the talus the talus. This is the talus, right? This is the talus. So the anterior portion of the talus is wider than the posterior aspect. So just think, if the wider aspect, when you do the dorsiflexion, it will be here, right? The anterior aspect, and it will stuck in this area, that means in the ankle mortise, and you cannot move your foot. There will be no movement, and that's why it is the most stable. But when you are doing the opposite thing, that means your posterior narrower aspect of the talus will be in relation within the ankle joint, okay, and your foot can move some sort of inversion and eversion, okay, and then that means you're having a wobble or less stable joint, okay, and that's why the ankle joint is most stable in case of the dorsiflexion position. Is it clear?
Yes.
Okay.
Sir, can
Okay.
we say that the more mobile the joint is, the lesser stability it has?
Yes, you can say, but you need to clarify why it is less mobile and why it is more mobile in dorsiflexion and plantar flexion as well. Okay. Okay. What are the muscles will make up the tendo Achilles? This is very easy. The GPS. Okay.
GPS.
The GPS. Okay. The structures pass behind the medial malleolus. So in the notes, there are 2 points. Don't go through the 2 points, only follow this one. Okay, only follow this one. So you can have the tibialis anterior, the tibialis, the extensor hallucis longus, also the extensor digitorum longus, the tibial vessels, the tibial nerve, and also the peroneus tertius. Okay, only few of them.
Excuse me, sir.
Either yes.
Yeah, this says that these are the structures passing behind, but they are actually all the structures ahead. I mean, in front of the medial malleolus. The ones that you just said.
These are the structure passes below the extensor retinaculum.
Yes. I'm saying the this one. This one.
No. Can you just scroll upwards, sir? Can you just scroll upwards?
Yes.
So
Here.
this, the one which is written in blue, structures passing behind, it should be structures passing.
Yes, there is a
in front of the medial.
Right. You are correct. That's why I'm saying there is a confusion here. Okay, don't go through both of them. Just go through only one. That is the tibialis. What I'm showing here now. This one. Okay. Just
thank you, sir.
The tibialis. There is a confusion. That's why. Okay. There is a confusion. I need to update this one. One thing. What are the structures passing behind the medial malleolus? So first of all, via the picture, you can see the tibialis posterior. Okay, the tendon of the tibialis posterior. Then the flexor digitorum longus. This one. Okay. Then the posterior tibial vessels. Then the posterior tibial nerve, and then the flexor hallucis longus. So please follow this one. I was incorrect. This is wrong here. This is somewhat written in incorrect manner. Okay. So please.
Maybe you have to edit.
Yes, I have to edit that.
Sir,
I have to edit. Yes, that's what I'm saying.
Only this one.
Yes. So I have to edit this one. Okay, and don't go through this. Just follow this one. Okay, and also the image.
Picture is okay.
Yes.
Right.
All right.
Sir, I think the one that you have written, those are actually the one that you have written, no? So I think that is the muscles in the anterior compartment of the leg from medial to lateral.
Yes, yes.
Yes, that passes deep
Yes.
the extensor
Yes,
retinoculum.
Shagun, you're right. You're right.
Because tibial anterior
I
extension
just
longus, I
have
think
to,
it's
yes, I have to edit that. Okay, that's why I don't want to make any confusion, and I was just trying to tell you, just don't go through that, but follow the second one, because the question is the structures passing behind the medial malleus. This is a very important question. Okay, so about the arteries of the foot. So very important artery is the arteria dorsalis pedis, and as all of you know, this is the continuation. This is the continuation of what?
Anterior tibial artery.
Yes, anterior tibial artery. Okay, so about the arteria dorsalis pedis, as you know, this is the continuation of the anterior tibial artery, and yes. So this is the anterior tibial artery, right? When it will pass the ankle joint here, it will be the
Arteria dorsalis
dorsalis pedis. Okay, after that, it will pass anteriorly over the talus and also the navicular, okay, and also pass over the intermediate cuneiform bones, okay, and it will go and yes, and also it will go and inferiorly, as you can see here, it will go down, okay, inferiorly, and after that it will be as a deep plantar artery between the two heads of the dorsal interosseous muscle, where it will join with the deep plantar arch of the sole of the foot. Okay, so on the left hand side you are seeing the sole of the foot. Here you can see two arteries mainly. One is the medial and another one is the lateral, right? So both of them are the continuation of the posterior tibial artery. So the lateral one will be articulating with the dorsalis pedis. Okay, the lateral one. Yes, this is also as a deep plantar artery. So about the course, I'm saying again, please, the anterior tibial artery will become the dorsalis pedis artery when it is just passing the ankle joint. Then it will go in front of the talus, the navicular and the intermediate cuneiform, and go in between the two first dorsal interosseous muscle, and it will go downward or inferiorly, and it will become the deep plantar artery. And along with the lateral plantar artery, it will be articulating, it will having the connection with the lateral plantar artery, and it will be supplying those areas. And the lateral plantar artery is the branch of the posterior tibial artery, and also the posterior tibial artery having a second branch, which is the medial plantar artery. So all of those three will be giving the blood supply to the sole of the foot as well. Is it clear about the dorsalis pedis and along with the lateral and medial plantar artery of the sole of the foot?
Yes, sir.
Yes, sir.
Yes, sir.
It is easy if you can see and visualize, right? Okay.
Sir,
They can
we say, sorry.
No, go ahead.
Can we say the arteria dorsalis pedis is an end artery?
How can you say that?
No.
No.
No, you like see
No.
clearly you can see.
No.
Yes, you can clearly see it is. It has a anastomosis with the lateral plantar artery, so it cannot be a end artery.
Okay.
Okay.
The communication. Okay.
All right. They can ask you how to demonstrate the foot pulses on a living subject or a patient. So we'll be seeing the extensor hallucis longus tendon in a few shortly. So you can just simply say the dorsalis pedis artery. You can ask the patient, can you pull your toe towards you? Okay. So if the patient can do that, that means the extensor hallucis longus will be taut, right? So just lateral to it, you can put your finger to show the arteria dorsalis pedis. This is the extensor hallucis longus. When you are going to, when the patient going to dorsiflex the toe, okay, that means the extensor hallucis longus will be taut, and you can clearly see the tendon. Just put your finger lateral to it, and you can feel the pulse of the dorsal arteria dorsalis pedis. Okay, and where you can have that, you can found that in between the first two metatarsal bones. Is it clear about the dorsalis pedis?
Yeah.
Yes, sir.
Okay.
Can I explain? Dorsalis pedis, actually, it should be palpated just before the first intermetatarsal space over the navicular bone,
Yes.
and just lateral to the extensor hallucis longus.
Yes, you can say
Because because just the proximal part of the first intermetatarsal space, it dips down as the deep
yes.
dorsal
You
artery.
cannot
So
clearly
we should
feel that.
palpate it before the,
Yes, over the navicular one.
So we should palpate it just before the first intermetatarsal space over the navicular bone.
Yes, yes, yes.
Yeah.
You have to feel that against a bone. Then you can feel it better. You can feel it better. Okay.
Yes.
About the another one, which is the posterior tibial artery. So simply, you can have this, or you can feel the posterior tibial artery between the medial malleolus and the Achilles tendon. Okay. Simply, if you just say, I can feel it is a halfway between the posterior, the medial malleolus and the tendo Achilles. Okay, the posterior tibial artery. That's one way to say. Okay, and this is the easier way to say. Is it clear?
Yes.
Yes, sir.
Okay.
Yes, sir.
Now, as I said, we have to identify the tendons of the foot. Okay. So in this picture, you are seeing the dorsum of the foot. Okay. And okay, if you can see here. Okay. First thing first, you have to identify from this picture is first of all number 17. This is the tibialis anterior.
Tibialis anterior.
Yes. Okay. And you can see very long. Okay. Number 7, very long. Okay. And
Extensor
it is
hallucis.
going. Yes.
Extensor hallucis longus.
Fantastic. Extensor hallucis longus. And if you see in a very clearly, you will see there is a long tendon and also there is a short tendon for each one. This is the long tendon, this is the short tendon, this is the long tendon, and this is the short tendon. All of them has the same thing. So you can say number 7 is the extensor hallucis longus, and number 6, it will be the extensor hallucis brevis, because this is the short. Okay. So the same thing will you need to follow. You need to follow for the other one. Okay. So number 5, you can say number 5, it is the extensor digitorum longus, and on the side, number 4, it is the short one. So this is the extensor digitorum
brevis.
Yes. Okay. Okay. What else you need to see from this is another tendon, which is number 12. So number 12, it is the peroneus
Yeah, it's tertius.
Tertius.
Yes, the peroneus tertius. Okay, clear about this picture? This is a very easy
Yes,
picture.
sir.
Yes, sir.
So can you tell me about the marking number 3? Is it arteriodorsal pedis?
Yes,
Yes.
Number
yes,
3.
yes.
Okay.
All right. From this picture again, you have to identify the same tendons. Okay, but mostly the extensor hallucis longus. Can anyone tell me which one is the extensor hallucis longus?
14.
Fantastic.
Extensor hallucis longus is 14.
Fantastic. Yes, this is the extensor hallucis longus. Now it's very easy, right? This is very easy. Okay.
Yes, sir.
From here, one thing you have to know is what is number 1. This one. This is the extensor.
retinaculum.
Yes, the extensor retinaculum.
Retinaculum.
Okay. And if you can identify the arteriodorsal pedis from this picture, which one will be?
15.
It is
15.
12.
11.
11.
11.
11.
11.
Okay.
Oh,
11.
okay.
And
Okay. 11.
and the 15 also the
15.
continuation, but it's already going
ADP.
down, right?
Yes.
Plantar.
Yeah.
So this is the deep plantar branch. This is the
Deep
deep
plantar
plantar
branch.
branch. Okay.
Plantar branch.
But here, this is a purely the ADP,
Arteriodorsal
number
pedis.
11. Okay. So from this picture, again, what you need to know, number 1, it is the extensor retinaculum. Number 11, this is the ADP. Number 14, this is the extensor hallucis longus. Okay. And if you want to go more, then you can think about the deep plantar one from continuation of the ADP. Okay. Nothing else.
Okay.
Next picture about the same thing you have to identify. So now it is much more clear, right?
Yes.
Much more clear now, I guess,
Yes, sir.
for all of you. So here, simple. Number 14, same thing, the extensor hallucis longus,
Extensor hallucis.
Understand.
right? Okay. Again, the same, number 11, this is the ADP.
ADP.
Arteriodorsal pedis.
Yes, and also, if you can say more, number 15,
Deep plantar
this is
branch.
the deep plantar branch.
Deep plantar.
Okay. Okay. Here is a extra. What is number 10? So,
Tibialis
Tibialis
Anterior.
anterior.
fantastic. Fantastic. Fantastic, guys. Excellent. Okay. So, what is the movement of the extensor hallucis longus perform? So, as we know, it will extend the big toe, and also it will assist in dorsiflexion of the foot, and also
Inversion.
somewhat of inversion. Okay.
Inversion.
Same question. What vessels would you find deep to the extensor hallucis longus? So you can have this anterior tibial artery and vein. Okay. And what is the nerve you're going to have is the deep peroneal nerve. Okay.
Yes.
So artery is the anterior tibial artery and the nerve is the deep peroneal nerve. Okay. Where would you test the sensation of S1? S1 should be tested on the lateral aspect of the foot, right? And about the L4 over the medial malleolus. And what about the deep peroneal nerve? Deep peroneal nerve should be tested over the first wave space.
First wave space.
The first wave space. Okay.
Wave
And
space, yeah.
and about the superficial one, the superficial one is over the dorsum of the foot.
Dorsum of the foot.
Okay. What you left, you have the sural nerve, and the sural nerve is tested over the lateral malleolus. These are all from the part A. Okay. All of you, I know, this is very easy for all of you. This is from part A. Okay.
I think the lines are intermingled in that.
Yes. I will edit that. Yes, I know. Okay, about the reflexes, you have to perform these reflexes in your clinical exams. Okay, so you have to know them in a very correct fashion. About the knee reflexes, first of all, what you can do for a knee to see the knee reflex? Can anyone tell me? I want to hear from you first.
Can I answer, sir?
Yeah, Dr. Samir, go ahead.
We have to expose the
Everyone mute, please.
we have to expose
The patient
Dr.
is
Samir.
asked to sit by the. Yeah, sir. The patient may be asked to sit by the edge of a table with the legs hanging down and the knee flexed at 90 degrees. This will properly. We should properly expose the patient's lower thigh from the mid thigh level. Once the patella is clearly seen, you should try and delineate the patellar tendon, which is below the lower end of patella, going to attach at the tibial tuberosity. Once you identify the patellar tendon, then gently tap your hammer, the clinical hammer, on the patellar tendon, trying to elicit the patellar tap. You could see a jerk once you do that, indicated by the extension of the leg.
Okay.
If the jerk is too feeble to be appreciated, you can try and appreciate the contraction of the quadriceps tendon.
Okay. Dr. Samir, you are saying correct. Can you tell me where you are looking while you tapped?
If if I tap properly, then I would be able to see the extension of the leg happening. If the extension of the leg is not happening, the patient is too conscious about holding the leg, then I would be seeing the contraction of the quadriceps muscles and the exposed part of the thigh.
Yes, fantastic. So before you do, first thing first, you need to expose the patient thigh. That's first thing. Okay. Next one, the patient knee or foot should be unsupported and relaxed. Okay. Then after that, you are going to tap over the patellar tendon with a tendon hammer, and you are going to see the contraction of the quadriceps muscles by looking over the thigh of the patient. Okay. Clear?
Do we have to actually elicit the reflex, or is it just will be told
In the clinical exam? In the clinical
yeah.
exam, you just have
Okay.
to act. You just have to act. Okay. In the clinical examination, you just have to act, nothing else. Okay. About the ankle reflex, anyone know how to do the ankle reflex?
Yes, sir.
Go ahead. Let us know.
Yeah. Ankle reflex can be elicited by two methods. Number one is just flexing the knee joint and supporting the ankle over the opposite part of the lower leg, and then just tap over the tendon Achilles tendon,
Yes.
and we will see the reflex over the calf muscle and contraction at the ankle joint.
Yes.
So there will be plantar flexion.
Yes. Yes. Very good. So first thing first, again, about the ankle reflex, you need to expose the patient's calf. That's the first thing you are going to do. Okay. Next one, you can just put the patient foot laterally. Okay. And knee is flexed and relaxed, and your calf muscle should be fully exposed. Next, you are going to tap over the Achilles tendon with a tendon hammer, and you are looking for the contraction of the calf muscles. If there is a contraction of the calf muscles, then obviously there will be plantar flexion of the patient foot. Or maybe you can just see a little bit of contraction and there is no plantar flexion as well. Okay. Next is, what are the nerve roots of the reflexes? So for the ankle one, it is S1, and for the knee reflex, it is the L3 and L4. Okay. So the same question here.
Hello.
Yes, Dr. Sneha.
Yes, sir. Sir, for ankle reflex, it is like L5 S1 or S1 S2?
S1.
Like if
Ankle
two
1,
options
ankle
there
is
will be.
S1. Ankle
Okay,
reflex
only
is S1 and the knee reflex is L3, L4.
okay.
Okay. There are a few questions like what movement is ankle dorsiflexion? So mainly the dorsiflexion means the patient's foot will move upwards towards the patient, right? So how can you as the patient or how can you ask the patient to do the dorsiflexion is simply just ask the patient, can you move your foot towards you? Okay, so this will be the dorsiflexion. How can you say about the plantar flexion? Simply say, can you move your foot opposite to you? Okay, so that will be the plantar flexion. So what is the ankle inverters? As already all of you know, the two muscles will be involved in inversion, that is the tibialis anterior and the tibialis posterior. Okay, and all of these questions are already I have talked. What are the inverters? The peroneus longus and the brevis. Okay, all right, so let's talk about the muscles. Okay, about the leg muscles. About the leg muscles, first thing first, you have to know there are mainly three compartments of the leg muscles. One is the anterior compartment. Second one is the lateral compartment. And the third one is the posterior compartment. And the posterior compartment is subdivided into two parts, right? One is the superficial and another one is the deep. So you have to know how those compartments are divided and via what. So first thing, the anterior compartment, it is divided with the posterior deep compartment with the interosseous membrane. The anterior compartment again is divided with the lateral compartment with the anterior intermuscular septum. So there are three intermuscular septum and one interosseous membrane. The interosseous membrane is separating the anterior compartment with the deep muscle group of the posterior compartment. Okay, the intermuscular septum is dividing the anterior compartment and the lateral compartment. And the posterior intermuscular septum, it is dividing the lateral compartment with the posterior compartment, both of them. And there is transverse intermuscular septum, which will be dividing the deep muscle group and the superficial muscle group. Is it clear till now? Is it clear till now, please? How those are divided? Everyone, is it clear? Please reply. Hello, am I audible? Hello? Sorry, there is a certain blackout suddenly. Am I audible to all of you?
Yes.
Yes, sir.
Okay, I'm sorry. There is a sudden blackout
Yes.
there. Okay, how far you guys hear me?
Yes.
The intermuscular septums.
Okay, so the three compartments is the anterior one, the posterior one, and the lateral one, right?
Yes, sir.
There are
Yes,
three.
sir.
Okay. Sorry about the disruptions. Please pardon me here. I cannot do anything about that. Okay. So the anterior compartment, it is separated via the interosseous membrane, and it will be divided from this posterior group, the posterior compartment. Okay. So there is one interosseous membrane and three intermuscular septum. One is anterior, second one is the posterior, and the third one is the transverse. Okay, The anterior intermuscular septum will be separating the anterior compartment along with the lateral compartment. The posterior intermuscular septum.
Anterior and lateral compartment.
Yes, the posterior intermuscular septum will be separating the lateral compartment with the posterior compartment. And the transverse one will be separating the deep group along with the superficial group of the posterior compartment muscle. Is it clear till now? Everyone?
Hello. We cannot hear right now. I think.
Can you hear me now, please?
Yes. Yes.
Okay. Is it clear about the compartments, how they are divided?
I guess I have missed some of the talk you have said. I have said for the past few seconds maybe. So far, I can listen that.
I say the last one.
Posterior intermuscular septum.
Okay.
Then there was a pause.
Okay. Again, the anterior one is separating the anterior compartment and the lateral compartment. Clear?
Yes, clear.
Okay.
Yes.
The posterior intermuscular one is separating the lateral one along with the posterior one as a whole.
Okay.
The transverse one, the transverse intermuscular septum is separating the posterior compartment, okay? And the posterior compartment has two groups. One is the deep and another one is the superficial. So it is dividing these two groups. Is it clear now?
Yes.
Okay.
Yes.
Okay, then let's talk about the leg muscles. Okay. I will try to do the same what I did. Okay. So you have the leg compartments. So in the long leg compartments, you have three groups, right? First is anterior group. You have the lateral group. And you have the posterior group, right? Okay, please reply because I cannot.
Yes, sir.
Yes,
Okay.
sir.
Yes, sir.
Okay. So then, first of all, in the anterior group, what are the muscles are there? So there is tibialis anterior, there is extensor hallucis longus, extensor digitorum longus, and the also peroneus tertius. Okay. On the lateral one, we have two. One is the peroneus longus and the peroneus brevis. Okay. On the posterior aspect, we have again divided into two, right?
Superficial and deep.
Yes. The superficial and the deep. Okay. On the superficial one, what are the muscles? G, P, and S.
Yes.
Gastrocnemius, plantaris, and the soleus. Okay. On the deeper aspect, what we have? We have the popliteus. Okay. We have the tibialis posterior. We have the flexor hallucis longus, and we have the flexor digitorum longus. Clear about the muscles of the
Yes,
leg compartments? Okay, let's put some nerves here. Okay, so anterior compartments will be supplied by the deep peroneal nerve. Okay, the lateral compartment will be supplied by the superficial peroneal nerve. And on the posterior aspect, it is supplied by
tibial nerve.
fantastic tibial nerve. Next is, if you can think like that, what are the movements? Okay, so as a whole, the anterior compartments are responsible for
dorsiflexion and inversion.
Dorsiflexion, okay, of the foot or the ankle joint, and we have some extra function of a special muscle, which is the tibialis anterior, and it will cause the inversion of the subtalar joint. Okay. On the lateral aspect, or the lateral group of muscles are responsible for eversion of the foot, okay, on the subtalar joint. And if you can think like about the posterior compartment, so these are responsible for the plantar flexion, okay, and we have a special muscle which is the tibialis posterior, and it is also responsible for
inversion.
Yes. Is it clear about the muscles, about the movements, about the nerve supply of all of those?
Yes, sir.
Okay.
Yes, sir.
If we think a little bit more, and if we want to put some vessels as well, okay, so you can put the anterior tibial, the anterior tibial vessels in the anterior compartment. In the lateral compartment, there is nothing. And on the posterior aspect, you can say there is a posterior tibial vessels. Clear for everyone?
Yes, sir.
Yes, sir.
Fantastic. So, Dr. Christopher?
Yes, sir. Good afternoon. Well,
Okay.
good night.
So, yeah. So now is it clear about the muscles?
Yes, sir.
Okay.
Thank you.
Yeah, no problem. So this should be opposite. Okay. This should be opposite. All right. About those muscles, no need for any attachment. Okay. And already we have, we already know what are the movements of those muscles and what are the nerve supply of those muscles as well. So you don't have to go through the this table. This table is very, I really don't like the tables, but I have put all of these tables just for your own references. If you want to look, you can, okay? But I really don't like the tables at all. Okay.
Sir, so we don't have to learn the origin and insertion of these muscles?
No need. I will say,
okay.
what are the origin and insertion of the muscles you need to know, as I said, in the upper limb, and also here in the lower limb, I will say, okay? Okay, about the nerves of the leg. What are the nerves we said? We had the deep one, we have the superficial one, and we have the tibial one, right?
Yes, sir.
Okay. What you have to know, from where they're coming. So mainly they're coming from the sciatic, right? The sciatic nerve. And what is the root value of the sciatic nerve?
Number 4, 5, section 1 to 3.
Fantastic. Okay. From the sciatic nerve, what are the nerves you can have? One is the tibial
The tibial nerve and the
common peroneal nerve. The common parallel nerve will be divided into two. The common parallel nerve is divided into two, and what? One is the deep and another one is the superficial. Okay. No need for the course of all of the nerves. No need. Just you have to know what are the nerves and from where they are coming and what are the muscles they are going to innervate, and we already know about those nerves. Okay. About the arteries, you have to know something. Let's start from the external iliac. What you are going to have from external iliac?
Femoral artery.
Then, yes, Dr. Fatima?
Popliteal artery.
No, from femoral, there are some branches as well. Okay, but if
Yes,
you're
yes,
just going
profunda
through,
brachii artery.
okay, from the femoral, you are going to have the popliteal. Yes, you are right. Then, from the popliteal, you are going to have
Anterior
Anterior
tibial, posterior
posterior tibial, anterior tibial.
okay, and the anterior tibial will be
arteria.
ADP. Yes, the lateral and the medial one. So this is a
Lateral and
little. This is a little bit of normal stance. Okay. Again, about the arteries of the leg, you don't have to go through all of the courses, all of the distributions. No need. Just you have to know a few of them. Okay. So I will try to show if it's there. Maybe yes. I think so. There should be somewhere. Okay. Okay, I will talk about that in a bit about the arteries, but from the artery, you have to know one thing is very important is this picture. Okay. So this picture is very important while you are identifying those arteries in the leg. Okay. So as you said, from the femoral, the continuation is the popliteal artery, right? So this is the popliteal artery. Okay. And from the popliteal artery, there will be one artery that is the anterior. This is the anterior tibial one. Okay. This is the anterior tibial artery. And you are going to have the tibio-peroneal trunk. From the tibio-peroneal trunk, you have again two artery. One is the posterior tibial and another one is the peroneal artery. This picture is very important and this picture comes in very often in your exam. So you have to know this picture very clearly. Is it clear now? Popliteal?
Sir, how will we describe it at first when we see it?
How can you know this is the popliteal one?
Do we have to tell that this is the arteriogram or?
Yes, yes. You have to say this is the arteriogram. Yes, this is the arteriogram of the leg. Okay. Is it clear about the branches?
Yes, sir.
This is easy and it will come in your exam as well. Okay. This is very, very important. Okay. So if the examiner asks you, can you demonstrate on a living subject about the movements of these muscles? All of you, can you do that about the tibialis anterior, the tibialis posterior, the peroneus longus, and the peroneus brevis, and the GPS? All I said about the dorsiflexion, the plantar flexion, the inversion, and eversion. Okay. Next question. Yes, please. Did anyone ask anything? Okay, no, I guess. Next thing, this is a question from the critical care. Okay, how can you recognize, how do you recognize the compartment syndrome in the lower leg? So first of all, the patient's leg will be swollen. Okay, there will be pain out of proportion. Also, there will be so much pain on active or passive stretching, and there will be paresthesia, paralysis, and the pulselessness. The pulselessness is the very late sign, and it is suggesting of impending limb necrosis. Okay, so how can you recognize the compartment syndrome? The leg will be swollen. There will be pain out of proportion. Also, there will be pain on active or passive stretching of the ankle. There will be paresthesia, paralysis, and pulselessness, which is a very late sign, and it can suggest the impending of limb necrosis. Is it clear?
Yes, sir.
Okay. Next, as I said, about the superficial and deep peroneal nerve. If there is an injury, here, so normally you are suspecting to have a injury to the common fibular nerve, the common peroneal nerve, and from the common peroneal nerve you are having the superficial and the deep. Now, can anyone tell me, if there is an injury to the common peroneal nerve, what are the muscles will be paralyzed, or what are the muscles will be involved? As I just mentioned, all of them. One by one, please. One by one, please. Dr. Udita, you can go ahead.
Yes, sir. Anterior compartment and lateral compartment muscles will be paralyzed.
And what are the sensory supply? What are the sensory?
And for sensory, for some of the foot and first with space.
Right. Yes. Very simply. Okay. This is very easy now. Okay. Fantastic job, guys. Okay. Now we are going to see some of the leg bones. First of all, this is the what you are seeing in picture A. Anterior aspect of the. Okay. How can you orientate? How can you orientate this bone? Can anyone tell me how can you orientate this bone?
If the whole tibia bone is given, then you can orient it in such a way that tibials will be placed anteriorly, and medial malleolus will be placed medially, and the articular surface for the condyle of the femur will be placed superiorly.
Okay. First thing, yes, you said in a very quick, very good way. So first of all, the tuberosity will be on the anterior aspect, right? That's very nice. Next, what you are going to see about the articular. What did you say? The articular?
Articular surface of the tibia will be placed superiorly.
Yes. Okay. What about
fibular articular part will be placed laterally.
Yes. What else? What is the significant points?
The interosseous membrane.
No.
Border.
What is the significant points on the posterior surface? Is number 12. Okay. Number 12, the soleal line. Yes. So you will just put the tuberosity in the anterior aspect, the soleal line on the posterior aspect. Okay. Next thing, you need to put the condyles, right? There are two condyles. One is number 6 is the lateral condyle, and you have number 9 is the medial condyle. So you can say the lateral condyle is larger, see, than the medial one.
Yes.
Okay. So let's identify then some points. Number 14, it is the tuberosity, the tibial tuberosity. Number 6, it is the lateral condyle. And number 4, which is a very important points, this is the impression for iliotibial tract, also known as, can anyone tell me? It is a tubercle. Excellent. Excellent, Dr. Samir, Dr. Shagun, excellent. This is the Gerdy's tubercle, and there will be the attachment of the iliotibial tract. Okay, on the picture B, what you need to identify is the soleal line, which is number 12. Again, you have the lateral condyle and you have the medial condyle on the number 9. Okay, these are the points you have to identify. Okay, next one is the lower end. In the lower end, what you have to identify is very simple. On the picture D, you can see both the tibia and the fibula is joined together here in this picture D, right? And you can say number 11, it is the medial malleolus. Number 9 here, it is the lateral malleolus. Okay, so if you can see as a single bone of the tibia, that means there will be only malleolus, which is the medial side, on the medial side. So if you are holding a tibia, then you can put this malleolus on the medial side. And if you can think all of the points, the tuberosity will be in anterior, the soleal line will be on the posterior aspect, and you can put the medial malleolus on the medial side, and you can just compare what about the lateral condyle and the medial condyle. Is the lateral condyle is larger, then that means you are holding the bones in a correct fashion. Clear? Is it clear?
Yes, sir.
Okay. About this picture. So you are seeing the tibia and fibula. This is articulated, right? So as we know, the fibula will be on the lateral aspect, correct? The fibula will be on the lateral aspect. So you can say this is the number 12, if they can ask, what is number 12? So the number 12 will be the tibio-fibular joint, and this is the superior one, right?
Yes.
And what will be number 1 then? The number 1 is the styloid process of the fibula. Okay?
Yes, sir.
Or you can say this is the apex of the head of the fibula. Okay. Next bones we have to talk about is the femur. Okay. In picture A, what you are seeing in picture A, this is the
Anterior.
Mhm.
Sorry, posterior view.
No, which femur?
Right.
Which femur? This is right or left?
femur. Right.
Sorry.
This is left femur.
This is left. This is left. Why this is left, right? So
Because this is the anterior aspect.
yes.
Anterior aspect.
Yes. So you are seeing this from the anterior surface, right? This is the anterior aspect. You are seeing this from the front. Why? Because the head lies on the medial aspect, medially, right? Second point, the greater trochanter, which is number 2. You can see the greater trochanter in a very clearly about the greater trochanter, and a small part of this, the lesser trochanter, which is number 5, in a very short way, or you cannot see in sometimes as well. Okay, but if you are seeing from the medial aspect, which is number B, you can see the laser trochanter clearly. Okay, and also you can think about a line, which is number 4. Number 4, it is the intertrochanteric line, and where when you are seeing the same thing, okay, there is a second, the intertrochanteric line. What does it mean by the intertrochanteric line? Because it is attaching both of the trochanter, the large one and the smaller one. That means it is attaching the greater trochanter along with the lesser trochanter via the intertrochanteric line in the anterior aspect. Okay, but in case of the medial aspect, or if you can say on the posterior aspect, you can say, or you can see actually in this picture, which is number A. Okay, in number A, you are seeing the left femur from the back. Okay, so again, this is number 3, this is the greater trochanter. Number 8, this is the lesser trochanter, and this number 5, it is
intertrochanteric crest.
Yes, it is joining these two trochanter. Okay, and this is now known as the intertrochanteric crest, not the line. Okay, also there is a single point here, which is number 12, and the number 12 is the quadrate tubercle. So about the identifying points and how you can orientate, is it clear for all of you?
Yes, sir, clear.
Okay, so let's try to identify a few points again. Okay, so number 3, anyone can tell with me. Number 3 is
Head of femur.
yes. Number 2,
Greater trochanter.
number 5,
Lesser trochanter.
number 4.
Intertrochanteric line.
Fantastic. On this picture, number 11, it is
Neck of the femur.
fantastic. Number 8,
Lesser trochanter.
Lesser trochanter.
number 3,
Greater trochanter.
number 5,
Intertrochanteric crest.
number 12.
Quadrate tubercle.
Fantastic, guys. Okay, we have to know one more identifying points, which is number 13. Okay, and number 13, yes, the linea aspera. Okay, this is the linea aspera. Okay, fantastic, guys. You guys are very smart and you can learn so easily, and that's very good. Okay, that was the femur from the upper end. So now we have to learn the femur from the lower end. Okay, okay. How can you orientate the femur in the lower end? Already we know how to orientate the femur, right? But there are few other points or few other extra points if you can orientate if they give you just the picture of the lower end of the femur. So you have to know this is the femur and how can you orientate. First of all, in picture A, as you can see, this is again the left femur and this is the lower end. How? So here, number 1, this is the adductor tubercle. Okay, and the adductor tubercle will be there only on the medial side. And how it is the medial side? Because number 9, this is the medial epicondyle. Okay, this is the medial epicondyle. And on the opposite side, number 6, this is the lateral epicondyle. And on the picture B, this is you are seeing from the front, and on the picture B, you are seeing from the back. So here you have the epicondyle also. That means you are going to have the condyle. So from the back, if you can think Okay, so this will be number 5. This will be the lateral condyle. Number 8 will be the medial condyle. Number 9, this is the medial epicondyle, and just above that, number 1, this is the adductor tubercle. Okay.
Yes, sir.
And if you can think a little bit about number 4, so what will be number 4? This is the intercondylar fossa. Is it clear? All of the points, all of the identifying points, please. This is very easy if you can think clearly. Okay. Should I go again? Or it's clear? Okay. Next is the blood supply of the head of the femur. Okay. So as all of you said, the femoral artery will be originating from the external iliac, right? Then the femoral artery will be giving rise to the profunda femoris artery. This is the profunda femoris artery. Okay, the profunda femoris artery will be given 2 branches. One is the lateral circumflex, and another one is the medial circumflex femoral artery. Now, these lateral circumflex femoral artery has 3 other branches. One is descending, which is going downwards. One is transverse, and another one is the ascending one. Okay, so this ascending branch of lateral circumflex femoral artery will be anastomosing with the medial circumflex femoral artery here, and this is the main blood supply for the head of the femur. Okay, there are some other associated blood supply, something like the obturator artery can give rise to the acetabular branch, and via the ligament, okay, the ligament of the head of the femur, it will enter into the head, but sometimes it is very less. Okay, so if there is a fracture, here, there is a chance of developing the same avascular necrosis of the head of the femur. Is it clear about the artery supply of the head of the femur? Is it clear to all of you?
Yes.
Yes, sir.
Okay.
Clear.
So if they ask from where the arteries are arising, so very simple. The medial and lateral are originating from the profunda femoris, and the ligamentum teres, it will be originating from the obturator artery. Okay, very easy. This is very easy. Okay. About the thigh muscles, let's try to simplify again. You guys can share with me. Okay. In the thigh, what are the compartments we have in the thigh? First is the anterior. Okay. Second one is the medial. And third one is the posterior. Okay. So on the anterior aspect, what are the muscles we have in the anterior aspect? So first of all, sartorius. Okay. Second, the quadriceps femoris, right? And the quadriceps femoris are 4.
Yes, sir.
the rectus femoris. Second one is the vastus medialis,
Vastus lateralis.
vastus lateralis, and vastus intermedius.
Intermediate.
All the muscles will be supplied by femoral nerve. Okay. What are the action? What are the action of those muscles? So
extension of the knee.
First of all, let's talk about the sartorius. The sartorius will cause mainly the flexion of the hip joint. Okay, and all the other muscles. Yes, there will be extension of the knee joint, and also there will be flexion of the hip. Okay, clear about that? Okay.
Yes.
Yes, sir.
Next, the medial. So on the medial aspect, what are the muscles we have? We have the pectineus, we have the gracilis, we have the adductors. Okay, in the adductors, there are three, right?
Three.
Longus,
Yes, sir.
Magnus.
brevis, and the
Magnus.
magnus. Okay, so all the muscles are supplied by obturator, except
Pectineus.
Except adductor
Adductor magnus.
adductor
Part of
pectineus.
magnus, right?
Yes, the pectineus is where the femoral and the adductor magnus lateral half, right?
Yes, sir.
The lateral half. The lateral half is via the sciatic nerve. Okay. About the function, mainly those are adduction. There will be adduction. Okay, there will be adduction. Okay. Last one is the posterior. And this is very important. Posteriorly, we have the hamstrings, right?
Yes, sir.
We have the hamstrings. Okay, mainly in the hamstrings, we have two types of muscle. Okay, one is biceps femoris, and the second one is the semi. Okay, semi has two parts. One is semi-tendinosus and semi-membranosus. Okay, and all the muscles are supplied by the sciatic, or you can say the tibial part of the sciatic nerve.
Yes, sir.
Clear?
Yes, sir.
Okay. I really don't like to go through, all the tables. So I try to simplify, and yes. So I think now you guys got the idea of that. Okay, but we have to know few origin and insertion of few muscles. Okay, few of them. So first thing we have to know about the iliopsoas. So about the psoas major, okay, it is coming from above to below, right? So it will be originating from the thoracic 12 to lumbar 5 vertebra and the discs as well, okay, and it will insert into the lesser trochanter of the femur. Yes, okay. About the iliacus, it will be originating from the iliac crest, also from the anterior sacroiliac joint ligaments, and it will insert also into the lesser trochanter of the femur. Is it clear about the origin and insertion of the psoas major and iliacus, or as a whole of the iliopsoas?
I think it
Yes,
will be
sir.
iliac fossa of the iliac plate or iliac crest.
Iliac crest. The iliacus is from the iliac crest mainly. Okay, you can add the iliac fossa, the ala of the sacrum, but mainly you have to say the iliac crest and the anterior sacroiliac ligament. These two is very important.
Actually, iliac crest, that is the inner lip of the iliac crest. No.
Yep. Yes.
Because from outer lip, the yes, maximus, medius, and minimus, and above
Yes.
this the external oblique abdominis.
Yes. Yes, you are
From
right.
the outer lip.
Yes, you are right.
The lip.
Okay. So about the quadriceps, okay. About the quadriceps, you have to know the origin and insertion as well. So the rectus femoris, as you can see, this is the rectus femoris, okay. So the rectus femoris will be originating from the anterior inferior iliac spine mainly, okay. You can see here. Also some part from the ilium superior to the acetabulum. The vastus lateralis will be originating from the greater trochanter, also from the lateral lip of the linea aspera. The vastus medialis will be originating from the intertrochanteric line and the medial lip of the linea aspera, and the intermedius is from the anterior and the lateral surface of the shaft of the femur. Okay. Insertion is easy. All of those muscles will be first, they will form the quadriceps femoris tendon, right? Then they will insert over the patella, and then they will form into the patellar ligament, and they will insert into the tibial tuberosity. Insertion is easy, but the problem is in the origin. Okay, for the origin, I'm going again because it's a little bit confusing maybe. So the rectus femoris will be originating from the anterior inferior iliac spine and the ilium superior to the acetabulum. Okay, so from this area. The vastus lateralis will be originating from the greater trochanter and the lateral lip of the linea aspera. The vastus medialis will be originating from the intertrochanteric line and the medial lip of the linea aspera, and the vastus intermedius will be originating from the anterior and the lateral surfaces of the shaft of the femur. All of these muscles will be formed into the quadriceps femoris tendon, and they will insert over the patella, and they will form into the patellar ligament, and ultimately they will insert into the tibial tuberosity. Is it clear? And I hope all of you know the nerve supply because I have told everything here. Is it clear for all of you, please? Please
Yes,
reply.
sir.
Yes, sir.
Okay.
Clear.
Yes, sir.
The last origin and insertion you have to know is the hamstrings. Okay, and this is very important again, but this is again very easy. Okay, in the hamstrings, what we had the biceps and we had the semis, right? Semis means the semitendinosus and the semimembranosus. Just remember, it's very easy. All the hamstrings will be originating from the ischial tuberosity. All the hamstrings. And there is an exception as well. What is the exception? The short head of the biceps femoris. The short head, this is the short head here. It's short, right? This is the short. The short head of the biceps femoris will be originating from the linea aspera. Easy origin of the hamstrings. All the hamstrings, like the semis and the biceps, the long head of the biceps femoris, will be originating from the ischial tuberosity, except the short head. The short head will be originating from the linea aspera of the femur. Clear about the origin?
Yes, sir, clear.
Okay. Let's talk about the insertion then. So what you have, the on the medial side, you have the semimembranosus and the semitendinosus. And on the lateral aspect, you have the long head and the short head of the biceps, right? So again, this will be so easy. So if you can think, the semitendinosus, this is the semitendinosus, it will be attaching on the pes anserenus. And what is the pes anserenus? This is the superior part of the tibia on the medial surface. And there are mainly 3 muscles that will attach over there, right? The 3
Yes.
ligaments, sorry. So first thing first, the semitendinosus will be, the attachment, the distal attachment will be there on the medial surface of the superior part of the tibia. Okay. Next thing, the semimembranosus. It will attach over the same area, but mostly it will be attaching on the posterior aspect. You can see here on the posterior aspect. Okay, and posterior part of the medial condyle of the tibia. Is this too clear about the attachment?
Yes, sir.
Okay, if this two is clear, then the biceps femoris, the long head and short head, is very easy. Okay, these two will attach normally on the lateral side of the head of the fibula. Here, lateral side of the head of the fibula. Okay. About the nerve supply, all the hamstring muscles are supplied by the tibial division of the sciatic nerve, except the short head. The short head will be supplied by the common fibular division of the sciatic nerve. Clear? All of the muscles,
Yes, sir, clear.
all of the muscles, if they contracts, okay, what will be the action?
Knee flexion.
Knee flexion, extension of hip.
Yes. So all of these muscles, if they contracts, then there will be flexion of the knee. Okay, that's the main function. And the secondary function, there is the extension of the hip joint. So there will be extension of the hip joint, and those function, that extension of the hip joint, this function is mainly via the semitendinosus and the semimembranosus. Is it clear for all of you? Please.
Yes, sir.
Okay, I don't know how I can make more simplified version of this. Okay, is it clear?
Yes, sir.
Okay, fantastic. If it's clear, then you have to identify few muscles from this picture as well. Okay, first thing first, you have to identify about what we learned in the first muscle in the thigh is sartorius, right?
Yes, sir.
Yes, sir.
So number 19 is the sartorius here. Okay, then you have to identify a few other things like rectus femoris. So number 17, it is the rectus femoris. You can see here as well, the rectus femoris. Okay, on the lateral aspect of the rectus femoris, what we are expecting to have the vastus lateralis.
Lateralis.
Okay, the vastus lateralis. Okay, and on the medial aspect of the rectus femoris, what we are expecting to have the vastus
Vastus
medialis, which is
medialis.
number 29. Okay, about number 12, this is the iliotibial tract. You can see from above down, this is the iliotibial tract as well. About some vessels, you have to identify from this picture. First thing is number 23. Okay.
Femoral vein.
Sorry,
Sorry,
number
artery.
6. Number 6. Sorry, number 6.
Femoral artery.
Femoral artery.
Femoral artery.
Femoral artery.
Fantastic.
Yes,
So,
sir.
fantastic. So, as we know, if you think like the femoral triangle, right? So,
Yes.
in the femoral triangle, what are the contents from medial to lateral? The femoral vein, artery, and the nerve, right? So, just think like that. So, the number 8 will be the femoral vein, number 6 will be the femoral artery, and number 7 will be the femoral nerve. Okay,
Yes, sir.
very clear. And if you can go further, then you can have this number 10, which is the great saphenous vein.
Great saphenous vein.
Okay, this is very easy picture, right? If you know how to orient it and how to go through it. This is a very nice picture, and you can have that. Okay, now we have very easy portion of the lower limb, and all of you already know all of these things. So first thing first, what is the boundary of the popliteal fossa? This is, I think now this is very easy. Okay, so this is a diamond shaped area. Okay, and you can have on the superior aspect, or you can say superolaterally, superomedially, inferiomedially, inferiolaterally, you can say that, or you can say on the laterally or the medially, whatever you want to say, no problem. Okay, so just say like this. On the superolateral aspect, what we have the semitendinosus. Okay, on the superior medial aspect, we have the biceps femoris. On inferolaterally, what we have the medial head of the gastrocnemius. On the inferolaterally, we have the lateral head of the gastrocnemius. And the floor is made of by the popliteal fossa. And on the roof, we have the superficial and the deep fossa. What are the contents of the popliteal fossa?
Yes, sir.
What are the contents of the popliteal fossa? This is again very easy. So you can say from superficial to deep. Okay, so the most superficial one will be your common peroneal nerve. Okay, or you can say yes, tibial nerve, or you can say this the common fibular nerve. This will be the most superficial. Then the tibial one. Then you can have the popliteal vein, and after that the popliteal artery. And sometimes you can have the lymph nodes, okay, posterior cutaneous nerve of the thigh, genicular branch of the obturator nerve, all of those things, but mainly these things. And this is very important to say in your exam. Next, is it clear about the popliteal one? This is very easy. And this is from part A as well.
Yes, sir.
Yes, sir.
Okay. About some differential diagnosis of the lump in the popliteal fossa. So in the skin, you can have the lipoma, the sebaceous cyst. In the joint, you can have the Baker cyst. In the artery, you can have the popliteal artery aneurysm. In the vein, you can have the varicosities. In the nerve, you can have the schwannoma, and in the lymph, you can have the lymphadenoma. So you can say what I have right like this, or you can simply say lipoma, sebaceous cyst, Baker cyst, aneurysm, varicosities, schwannoma. No problem. It's all of your choice. Okay, it's completely fine. Okay. Next is you have to know about this picture, and I think all of you already know about this picture. So what we had the popliteal artery from where? From the femoral artery, right? I was searching for this picture actually. Okay, so the femoral artery will go down and it will be converted into the popliteal artery in the knee, at the level of the knee joint. Okay, and then from the popliteal artery, you can have one is the anterior tibial, and you can have the posterior tibial one. And from the posterior tibial, you can have this division. Okay, here it is more clear, I guess. This is the popliteal one. It's going down, and it will be dividing here, the fibular or the peroneal. Okay, from the posterior tibial one, and the anterior one is going like this, and you can see the anterior one on this picture. Okay, and all of you know now how they can changes the anterior one into the ADP and the posterior one into the lateral and the medial, and the lateral one will be anastomosing with the ADP. Is it clear now? A little bit easy? Everyone, please reply.
Yes.
Everyone's
Yes.
voice is very low. Why? Are you guys tired or something?
No, it's okay. We are very much concentrated.
Okay, no problem. All right. So next, this picture is very easy picture, but in a first glance, you can think like this is a very tough picture, but no, this is very easy. And this is about the popliteal fossa, the contents of the popliteal fossa. Okay. So you guys now will tell me what you are seeing here. Okay. Who wants to participate then? First, tell me what is number 17.
Number 17.
That is the common.
Common peroneal nerve.
Fantastic. Yes, this is the common peroneal nerve. Okay. What is number 16? This is the tibial nerve. Yes. Okay. What is number 14?
Popliteal vein.
The popliteal artery. Okay. In the picture. Okay. In the picture, as I said in previous courses, in the picture, how can you differentiate between the artery and the vein? Always you will see the artery are a little bit round in shape. Okay, a little bit rounded in shape, and this is more tough. Okay, you can see this is a very tough structure, right? But in case of vein, it will be a little bit not a complete circular, and also it will be a little bit lax and somewhat in blackish in color in some pictures, a little bit blackish. Okay, like in this picture, as you say saw this, see the vein is a little bit of blackish.
Arteries are more glistening and whitish.
Yes, yes,
seems like
yes.
rubber.
Yes, yes, yes.
Sorry, but in case of popliteal fossa, popliteal artery is the deepest structure.
Yes.
Okay, no problem.
In the popliteal fossa, the popliteal artery is the deepest structure. You're right. What is the problem?
Is it popliteal vein or artery?
Number 14 is the popliteal artery. Because?
Yes.
Why? Because you are seeing the picture from the back.
Yes, thick also.
Okay, because you are seeing the picture from the back. That's why, and as you said, the popliteal artery is the deepest structure. That's why it is more upfront in this picture, right? Rather than the popliteal vein, which is in front of the popliteal artery, because you are seeing this picture from the back. Clear, Dr. Shakwat?
Yes.
Okay, and in front of the popliteal vein, you can see the tibial nerve, right? Here. Because you are seeing this picture from the back, the opposite aspect. Okay. On the right hand side, you need to identify again number 17. This is
Common peroneal nerve.
common peroneal nerve. Yes. And number 14, it is the popliteal artery. Okay. Same thing. You need to identify. Okay. Here you need to identify the hamstring muscles. Okay. This is again very easy. About the larger one, you can see this is the gluteus maximus muscle. Okay. In the hamstrings, what you need to identify. So on the lateral aspect, what you have?
Biceps.
The biceps femoris. On the medial aspect, we have semis, right? So one is semitendinosus
And membranosus.
This is semitendinosus, and we have this is semimembranosus. Okay. Again, here you can identify number 26. It will be the common peroneal nerve, and number 24. It will be the tibial nerve. Okay. From this picture, you need to identify the hamstrings and the two nerves you can see here. Okay. Here again a very nice picture. So from the abdominal aorta, you are going to have to the external and the internal iliac, and from the external iliac, you are going to have the femoral one. Okay, from the femoral one, what you are going to have? You are going to have the profunda femoris. Okay, and from the profunda femoris, you are going to have the lateral and the medial circumflex femoral artery. Okay, and then you are going to have a proper femoral artery. Okay, and from the profunda femoris, you are going to have some perforating arteries. Is it clear? This is very easy, but you have to identify this from a arteriogram. Okay, so you have to identify from number 2. So number 2 is the femoral artery. Okay, the femoral artery. Then if you go down from the femoral artery, here you are seeing some divisions. How can you understand which one is what? Can anyone tell me?
So number 4 is the...
No. How can you identify what is number 7, what is 6, what is 5, what is 3? How and why?
Number 6 looks like
the bone.
the profunda
The bone is
one by one, please. One by one, please.
According to the branches, number 6 has so many branches. Then number 7. So number 6 going to be profund.
Okay, simply, whenever suppose they just show you up to this.
Yes, sir. Artery near the bone
Yes.
is the profunda femoris.
Fantastic. Excellent.
Yes, sir.
Excellent. So the artery that will be near the bone, that is the profunda femoris, which is number 6.
Yes.
And from the number 6, you are having a branch, which is number 5. That means this is the perforating artery. Okay, what we left? We left the number 7. So number 7 will be the superficial femoral artery or the femoral artery, right?
Yes, sir.
Okay. And we had 2 circumflex. Remember, 2 circumflex artery, lateral and the medial circumflex artery. So number 3, this is the medial one. And number 4, it is the lateral one. Why? Number 3 is the medial one.
Number 3 should be lateral, no, sir?
3 is lateral.
Why?
Because it is going near to the bone.
Yes, but in
Because
the...
it is going towards. So number 3 should be lateral circumflex.
Yes.
And 4 should be medial.
Yes, you're right. But the problem is in the arteriogram on this picture, okay, this is the opposite. That's why I say, okay, normally you need to look for the lateral one in the anterior aspect, right? And the medial one on the posterior aspect. But especially in this arteriogram, this is opposite. Okay.
Okay.
So number 3, this is
should be medial.
Are you sure?
No, you are telling.
I was making you confused, and the same thing will be done in your real exam. Okay.
For me, this is lateral.
Usually,
yes.
Usually the medial circumflex femoral artery goes inside.
Yes.
And the
You
lateral
cannot see
circumflex
that.
femoral artery goes superficial.
Yes. Yes. I was trying to make Dr. Farhad sir a little bit confused. And I have succeeded with that. Yes. So in your exam, the examiner can make you confused in a lot of ways. Okay. So stick with your own things which you learned. Always be confident. Okay. And stick to that. So simply number 3, this is the lateral circumflex femoral artery because it will be on the anterior aspect and you can see that, right? And number 4, this is the medial one and you cannot see that. That's why you are not visualizing it properly. So number 3 will be your lateral circumflex femoral artery. Will be your medial circumflex femoral artery. Clear? I think now you are not going to forget this ever. Okay, fantastic. Sorry about that. All right. About the triangles. So here, this is the femoral triangle. Okay. So simply from the part A, all of you know, I guess, what are the boundaries. So the base will be the inguinal ligament. Okay. There is a medial boundary and the lateral boundary. The lateral boundary, as you can see, the lateral boundary will be formed by the medial margin of the sartorius, and the medial boundary will be formed via the medial margin of the adductor longus. Okay, and what are the contents? The contents from medial to lateral or lateral to medial, whatever you want to say, no problem. So from medial to lateral, it will be the femoral vein, the artery, and the nerve. Okay. Next thing is about the femoral sheath. Okay. In the this is the femoral sheath. Okay. The femoral sheath mainly, what is, if they ask what is the femoral sheath? So the femoral sheath, as you can see, this is a funnel shaped. It's a fascial tube. Okay. And almost it is 3 to 4 centimeter in length. And it passes down the inguinal ligament, and it encloses some femoral vessels. And there are some septa, the femoral septa. It is dividing the canal and some other compartments. Okay. Also, it can make one canal, which is the femoral canal, and all of you know the boundaries of the femoral canal as well. So on the lateral aspect, what you have, the femoral vein. On the medial aspect, what you have, the lacunar ligament. On the anterior aspect, what you have, the inguinal ligament. And on the posterior aspect, what you have?
Pectineal ligament.
The pectineal ligament. Yes. Okay. Okay. So the femoral sheath will be dividing this area into some compartments. So one of them is the femoral canal. In the femoral canal, what is the content? The Clockwitz lymph node. And what is the clinical significance of the femoral canal? The significance is during, sorry?
Femoral hernia.
No.
The femoral hernia can occur.
That can occur, but normally what is the main function of the femoral canal? During the increase,
during increased venous return.
yes, increase during the increased blood pressure, and also increase during the increased venous return. It will give the potential space for the femoral vein to expand. Okay.
Yes, sir.
That's the main function of this femoral canal. Okay. About the femoral canal, you have to know the boundaries, the contents, and the clinical significance, or what is the main function of the femoral canal. Okay. Next is you have to know, is very important, is the adductor canal. Okay. The adductor canal is also known as the Hunter's canal or the subsartorial or the adductor canal. All of these three things are the same. So it's normally, it runs from the apex of the femoral triangle to the popliteal fossa. Okay. What are the boundaries? What are the boundaries of the adductor canal? You have to know. So on the anterior lateral side, what you have? You have the vastus medialis on the anterolateral aspect. Okay. Anteromedially, you're going to have the sartorius, and posteriorly, you're going to have the adductor longus and few parts of the adductor magnus. What are the contents of the adductor canal? So you're going to have the femoral artery, the femoral vein, the saphenous nerve, and nerve to vastus medialis. Is it clear? Please, everyone.
Yes.
Yes. Yes.
Okay.
Yes, sir.
Next thing, you have to know about the surface marking of the adductor hiatus. So, everyone, remember the adductor tubercle. It is on the which side?
On the medial side.
Fantastic.
Medial condyle.
Fantastic. Okay.
End of the femur.
Okay. So if you can make a line from the anterior superior iliac spine to the adductor tubercle, okay, and you can put a simple line or a simple marking over the 2/3 of that line, okay, it will be your area for the adductor hiatus. Again, the points from the anterior superior iliac spine to the adductor tubercle. Okay, and in the line you are making a points or a area. Okay, this will be your area for the adductor hiatus, and you can say this is the area for the adductor hiatus. Is it clear?
Sir, whether this is the junction of the upper 2/3 and lower 1/3 of this line joining the AC anterosuperior leg spine and the adductor tubercle?
It is at the junction between the upper 1/3 and lower 2/3. Upper 1/3.
Upper 2/3 or lower 1/3?
No. This is so in the femoral. This is the femoral triangle, right? This is the femoral triangle, and this is the continuation of the femoral triangle, the adductor hiatus. So it will go a little bit down. Okay, it will go a little bit down, but you can correct me if I am wrong. No problem, sir. You are also my sir as well. Okay, you can correct me.
Because the adductor hiatus is actually the editors to the adductor magnus, no? And
Right.
where the femoral artery is dipping down to back of just above the popliteal fossa, where the femoral artery is becoming popliteal artery.
Yes.
No.
Yes.
And for this reason, I think it should be a line joining the anterosuperior leg spine and the adductor tubercle, and at the meeting point of
Junction?
upper 2/3 and lower 1/3. I think so.
What I mean is the adductor. Yes, you are right. Actually, I wanted to mean it should be on the lower aspect. On the lower aspect, on the
for this.
Yes, you are right. Yes, it should be on the lower aspect because it is the continuation of the femoral triangle, so it needs to be on the lower aspect. Yes, you're right. I was incorrect. So it should be on the junction between the upper 2/3 and lower 1/3.
And lower 1.
Yes, you're right. I was thinking it is lower, but when I was saying, I said in the opposite manner. Sorry about that.
Okay.
Yes, you are correct.
Thank you.
Yes, you are correct. Okay. Next thing, okay, about the boundaries, the contents, and the surface marking. Is it clear for all of you?
Yes, sir.
Yes, sir.
Okay, all right. Next thing is about the iliotibial tract. So the iliotibial tract, as you can see, this is the iliotibial tract. Okay. Normally, it has an upper attachment, and there is on the lower aspect, it has a attachment as well. So first of all, on the upper aspect, you can see here, it will attach with the tubercle of the crest of the ilium. Okay. And on below, it will be attaching with the lateral condyle of the tibia over the where there is a tubercle which is known as
Jari's tubercle.
Okay, it is attaching over that area. Okay, about the attachment. Okay, next, what are the muscles will be insert into the iliotibial tract? So there are two muscles. One is the gluteus maximus. Okay, this is the gluteus maximus. And another one,
tensor fascia lata.
Fantastic. So this is the tensor fascia lata. Okay, these two muscles will insert into the iliotibial tract. What is the clinical significance of the iliotibial tract as a whole? So normally, it stabilizes the knee joint. That's the first thing. Okay, it stabilizes the knee joint when the knee is in extension. Okay, also it will help during walking and running as well. And functionally, if you can think, this tensor fascia lata, it is normally stretching this tensor fascia lata okay, and it is like pulling this muscle into the lower thigh and also the leg, okay. And while you are doing the abduction and medial rotation, also some kind of flexion of the thigh, it will stabilize those actions and also helping the functions of the tensor fascia lata by extending these muscle towards the thigh, lower thigh, and the leg. Okay, this is the clinical significance, because all of these things can support this knee joint while you are running or while you are standing. Also, you are doing some other functions like you are bike riding or something. Then all of these muscles, all of these functions can be stabilized by this iliotibial tract. Is it clear, everyone?
Sir, can you please repeat once?
Which one? Which one? The function or the attachment?
function.
The muscles. Okay, function.
function.
First of all. Okay, first thing first. The iliotibial tract, mainly it stabilizes the knee. Okay, it will stabilize the knee. When the knee is in extension position, okay, it is extended position, and it will stabilizes the knee. Mainly, main function of the iliotibial tract is stabilization of the knee, okay. And the second function, as you can see, the tensor fascia lata will be inserting into the iliotibial tract, right? Mainly, yes. It is stretching the fibers of the tensor fascia lata down towards the lower thigh and also on the leg. So what does it mean? The functions of the tensor fascia lata will be more stabilized because it is having more attachments on the down and also over the iliotibial tract. And what are the functions? The functions are almost similar, like it will be stabilizing the knee joint, okay. And while you are doing some sort of abduction, medial rotation, also the flexion of the thigh, okay, it will help to do all of those functions. And also when you are standing for a long time, or you are walking, you are running, okay, all of these functions can be stabilized via this iliotibial tract. Clear now?
Yes.
All right. Next, we have to know about this hip bone. Okay, this is very simple. How can you orientate this bone? Can anyone tell me?
The acetabular notch lies laterally.
Yes.
And the anterior superior iliac spine and posterior superior iliac spine lies anterior. Sorry, anterior superior iliac spine and inferior iliac spine lies anteriorly.
The 5 and 4.
Yes, yes.
What about the
posterior tuberosity lies posteriorly.
Posterior, inferiorly.
Posterior, inferior.
Okay, fantastic, excellent, Dr. Fatima, very good. So we have to identify a few points from this bone. First thing first, let's talk about number 28. Okay, number 28, it is the tubercle of the iliac crest. Number 5 is the anterior superior iliac spine. Number 4 is what? Anterior inferior. Number 23. Yes, number 23 is the posterior superior iliac spine, and number 22 it is the posterior inferior iliac spine. Okay. Here, number 2, it is the acetabulum itself. Number 14, it is the ischial spine. Number 15 is the ischial tuberosity. Okay. And if you can think like this, number 19 is the obturator foramen. Fantastic. Okay, from this bone, you don't have to know all other identifying points, but you can think like something. There is a border. Okay, this border, if you can think an imaginary line like this will be the posterior gluteal line. If you can think like this will be your anterior and
gluteal line.
Yes, if you can think like this, it will be your inferior gluteal line. Okay. So, yes. Mainly, what are the muscles on the posterior aspect? You have to know. You have to know about the gluteus maximus, gluteus minimus, okay, and gluteus medius, which is not visible here. Sorry, the gluteus medius is visible, but gluteus maximus is not visible. And you have to know about other muscles like the piriformis, the gemellus, and the quadratus femoris. Okay. So why those are important? Because the attachment over the greater trochanter are those muscles. What are the attachments? One is the piriformis. Okay. Here, this is the greater trochanter. So one is the piriformis. Second one is the gluteus medius, and you can have the gluteus minimus. This is a cut version, and this is one is the gluteus minimus. Also, you can have these gemellus, okay, and you can also have the obturator externus. You cannot see from this one. And we have talked about one important points is the one tubercle on the femur. Can anyone tell me what was that?
Quadrate tubercle.
Quadrate tubercle, yes. And that is the attachment for?
Quadratus femoris.
Fantastic, fantastic. So every points was important. Okay, here is a picture. This is very important to know. On the posterior aspect, you can see this is, it was the posterior gluteal line, right? It was the posterior gluteal line. It was the anterior gluteal line, and it was the inferior gluteal line. So in between, okay, the posterior gluteal line, you can have the origin of the gluteus maximus. In between the posterior gluteal line and the anterior one, you can have the origin of gluteus medius, and below the anterior and above the inferior one, you can have the origin of gluteus minimus. Okay, so you have to know the origin of gluteus maximus, gluteus medius, and the gluteus minimus. The origin. About the insertion, the gluteus medius and the minimus will be inserting over the greater trochanter, right? What about the gluteus maximus? Can anyone tell me where it will insert?
Iliotibial tract.
Iliotibial tract.
Fantastic. It will insert into the iliotibial tract. What about the nerve supply? The gluteus maximus is supplied by inferior
gluteal nerve.
Fantastic. The gluteus medius and the gluteus minimus will be supplied by
superior
the function of the gluteus maximus is extension of the hip joint, right?
Yes, sir.
Okay, gluteus medius and minimus, the main function is the abduction. Abduction. Okay. Okay, so if there is an injury to the superior gluteal nerve, that means there will be less abduction, okay? Less abduction of that side. That means it cannot hold the hip on the same position, right? That means there will be sagging. There will be sagging. Where? On the opposite side. That means always remember SSS. What does it mean? The sound side
side sagging.
That means if there is a problem on the right superior gluteal nerve, that means there will be sagging on the left side.
On the left side.
Okay, is it clear?
Yes, sir.
What is the name of this clinical problem?
Trendelenburg.
Fantastic, guys. Excellent. Okay, so where does the gluteus maximus muscle insert? The gluteal tuberosity. What nerve supply and nerve roots of the gluteus maximus? So it is the gluteus maximus supplied by inferior gluteal nerve, and the root value is L5S1S2. What is the action of the gluteus maximus? Mainly, it is the external rotator and extension of the hip. What is the nerve supply of the tensor fascia lata? The superior gluteal nerve, along with the gluteus medius and the minimus. And about the nerves, muscle insertion, already all of you know. What is the action of the gluteus medius? Yes, mainly the hip abduction, okay? And they can support the body, okay? And like simply, they will keep the hip on a single line, okay? As I said, when you are trying to stand over your one foot, okay? And about the clinical significance, there will be a Trendelenburg gait, or when you are going to test that, there will be a positive Trendelenburg test. So which nerve? The supragluteal nerve as well. Okay, what are the causes? There are so many causes. So you can simply can memorize some of them, like maybe there are some weak muscles, weak abductor muscles like gluteus medius and minimus. Maybe there is some avulsion of those muscles. Maybe some there is L5 radiculopathy because of the nerve roots. Maybe there is an injury to the superior gluteal nerve, maybe myopathy or pain, trauma, neurological conditions like stroke, multiple sclerosis. All of those things can cause this Trendelenburg gait. And about the sign, these things we are going to have in the clinical examination. Okay, next is a very important thing about the surface marking of the sciatic nerve. Okay, about the surface marking of the sciatic nerve, you have to make 2 points. 1.1 is from the posterior superior iliac spine to the ischial tuberosity. Okay, this is 0.1. You can think like 1 point from the highest point of the iliac crest. If you can make a line like this, okay, this will be the first point of when you are doing the surface marking. So here, when just below the piriformis muscle, you can point a space here for the first point. Okay, again, first thing, you need to draw 2 lines. First line should be from the highest point of the iliac crest to the ischial tuberosity, and you can make a point just below the piriformis muscle. That's 0.1. Second point should be from the greater trochanter to the ischial tuberosity, okay? And you can make again a point onto that place. Now, if you make a curved line between these 2 points like this, it will be your surface marking for the sciatic nerve. Is it a little bit difficult? Should I go again?
Yes, sir.
Again?
Yes, sir.
Okay. First point, you need to draw a line from the highest point of the iliac crest to the ischial tuberosity. Okay? And the lower border of the piriformis, you can make a point here. Clear? First point, first of all, you need to make 2 points. Okay? So first point is here. Up to now, till now, is it clear?
Yes, sir.
Yes.
Okay. Second point, you have to make again a line from the greater trochanter to the ischial tuberosity again. Okay. And you have to make a point here. Now, if you are trying to merge these 2 points with a curved line, just like this, it will be your area for the sciatic nerve. Now is it clear?
How did I put the second point?
You can put the second part just medial to the laser trochanter, or you can think like the medial and lateral. If you can divide this on 2/3 and 1/3, you can make a point on the junction of the lateral 2/3 and the medial 1/3. You can do the both things, no problem. Okay.
Okay.
Now is it clear for all of you?
Yes, sir.
Okay. All right. Next thing about the course of the sciatic nerve. So the sciatic nerve mainly. Okay. I think I was searching for some picture, but I don't think so. There is a picture. Okay. The sciatic nerve, it runs mainly inferolaterally, right? You can see from this, it will run inferolaterally, but it will be under the cover of gluteus maximus muscle, right? And it descends down from the gluteal region to the posterior thigh. Okay, if you can see in this picture, yes. Okay, so it will descends first of all inferolaterally under the cover of the gluteus maximus muscle. Okay, suppose you can have this gluteus maximus here. It will run under the cover of this gluteus maximus, runs inferolaterally, and then it will go from the gluteal region to the posterior thigh like this. Okay, and in the posterior thigh, in this area, it will lie posterior to the adductor magnus and deep to the biceps femoris muscle. Again, the sciatic nerve, it will run inferiorly and laterally. As you can see, this is a curved line, and it will run under the cover of the gluteus maximus, and it will go down from the gluteal region to the posterior thigh. In the posterior thigh, it will lies posterior to the adductor magnus. Okay, it is posterior to the adductor magnus, but deep to the long head of the biceps. Is it clear now? It will be much clearer if I can show you some pictures, but there is no picture. I'm sorry. Is it clear? A little bit, please reply.
Sir, could you say
Yes, sir.
last part?
Okay, no problem. Yes, no problem. Okay. So the sciatic nerve will run inferolaterally. You can see, right? This is going downwards and somewhat laterally. So it will go inferolaterally, but it will be underlying the gluteus maximus muscle. And it will go down from the gluteal region to the posterior thigh region. As it was the undercover of the gluteus maximus in the posterior thigh, it will be anterior to the long head of the biceps, but posterior to the adductor magnus. Or you can say in a different manner, you can say this will be on the posterior to the adductor magnus, but deep or anterior to the long head of the biceps.
Thank you, sir.
Is it clear? Not clear? Please, Udita.
Yes, sir. Yes, sir. Clear.
If you can visualize, right? Suppose, how can you? If you can think, this is the adductor magnus. Think, okay? This is the adductor magnus.
Yeah.
And this is the biceps femoris. So the sciatic nerve will be just here. So
In between them. Okay.
yes, the posterior to the adductor magnus, but anterior or
anterior to the biceps.
And to the biceps femoris. The sciatic will be there on the thigh.
Okay.
Yeah.
Thank you, sir. Yeah.
Okay. I think you need to have some visualization. I'm sorry, I didn't put the picture. Sorry about that. Okay. About the variations of the sciatic nerve. Okay. About the variations about the sciatic nerve exiting the pelvis, how they can have some variations. So normally, the sciatic nerve in a normal patient, the sciatic nerve will be emerging by the greater sciatic foramen, and it is bound together in a single connective tissue sheath, and they will be emerging below the piriformis muscle. Okay, in a normal patient, this is the normal variant. But as we know, the components of the sciatic nerve are two. One is the common peroneal and another one is the tibial. Okay, so in 12% of patients, the common peroneal part will be emerging within the piriformis muscle, but the tibial one will be remaining in the same place. And about 0.5% cases of patient, the common peroneal part will be emerging above the piriformis muscle. Okay, so you have to know the normal variation and B and C. Okay, these are very rare, and you don't have to know about this for the OSCE. Is it clear about the variation?
Yes, sir.
Yes, sir.
This is very, very easy. Okay, next question. What is the nerve related to the anterior superior iliac spine? This is from part A. You guys can answer me. What is the nerve related to anterior superior iliac spine? This is
lateral femoral cutaneous nerve.
Lateral cutaneous nerve to the thigh. Yes. If there is a compression over the lateral femoral cutaneous nerve, what will be happening?
Neuralgia parastica.
Fantastic. Fantastic. Very good. Very good. This is from the part A. Okay. Next question is about the vascular lacuna. What is the lacuna? What is the lacuna? There are two types of lacuna. One is the lacuna vasorum and another one is the lacuna musculorum. Okay. Normally, this is a compartment. This lacuna, this is a compartment within the inguinal ligament. Normally, it allows the passage of the femoral vessels, lymph nodes. Okay. So these lacuna are two types, as I said, the lacuna vassorum, and there is another part that is lacuna musculorum. You have to know the components of those two parts. Okay. So on the lacuna vassorum, if you can think like this, by the name itself, as it says, the lacuna vassorum, that means you're going to have some vessels and few one nerve actually. So what are the vessels? First thing first, you're going to have is the femoral vein. Same thing, exactly the same thing, the femoral artery, and just behind the femoral artery, what we had the femoral branch of the genitofemoral nerve. Okay, so in the lacuna vassorum, the contents are femoral vein, femoral artery, femoral branch of the genitofemoral nerve, and also you can say the deep inguinal lymph nodes as well. And what about the contents of the lacuna musculorum? Because it is mostly on this part, okay, and it will contain only the femoral nerve. Is it clear about the contents of the lacuna vassorum and the lacuna musculorum? This is very easy. If you can think like the femoral triangle and the contents of those things, this is the same thing as well. So vassorum, because it contains some vessels. Musculorum, because it contains nerve. No. It will contain some other parts as well, because as I said, the musculorum, that means it will have some muscles as well. Which muscle? So it will be having the iliopsoas. Okay, the iliopsoas along with the femoral, and also you can see, if you can think like this, okay, the muscular
Lateral femoral cutaneous.
Yes, the lacuna musculorum. So the femoral nerve, lateral femoral cutaneous nerve, and the iliopsoas. Is it clear about the contents of those two, lacuna vassorum and the lacuna musculorum?
Yes, sir.
Okay, fantastic. And that was the last question for all of you. I'm sorry, tonight I extended it long. Sorry about that. But this is the end of the lower limb. Okay, did you guys understand?
Yes, sir.
All of you?
Yeah, thank you.